Qureshi, who's at the Office of the UN Special Envoy for Health and Agenda 2030 and for Malaria, and also the Interim Project Director for Financing Alliance for Health.
Thanks. Thank you. I first want to just thank the Academy for inviting me. It's hard for me to imagine I have anything worth saying to such an esteemed group, but I will try to live up to the invitation. So very much appreciate you all inviting me here. Also to recognize the organizers for putting together such a great day. It's tough to be the panel after lunch in a warm room, so I'll also try to be a little humorous if I can. But I also, really think this topic of financing is absolutely critical, and it's sort of central to the day. It was central to the discussion this morning, and I hope to pick up on a lot of themes that were discussed. In particular, two things. One is this idea of strong primary care, and community health within that is something I'll talk about, but strong primary care as the platform for delivering a lot of critical interventions. And the second, this point on domestic resource mobilization that Natasha touched on briefly, but also that Dr. Merson asked about this morning, Dr. Chin as well, and that Ambassador Kolker also spoke about. But really, how do we do that? What does that mean? It's a bit of the elephant in the room. We all know it's important, but what does that look like? Okay, so Megan and the organizers asked me to talk about a couple of specific things. One is the challenges around financing. Two is what we've seen is kind of working out there. And then how the U.S. government can better support that transition. And then fourth, and kind of to Dr. Chin's question, the role of mHealth tools in delivering care at a more affordable price point and increasing access. So I'll try to do those as much as I can, while also being brief. Okay, just a bit of background. I could skip this slide, but basically, as we all know, supply and demand are not equal in what we need with finance, right? We have a major problem with countries wanting to do really aggressive and fantastic things with their primary care systems in particular, but also with their health systems more broadly, but just not the bolus of funding we need to get there. Abuja targets, we have a slide in the backup, but no country's actually hitting their Abuja targets, or sorry, very few are. And we know, as was discussed this morning, that we expect donor commitments to be, at best, probably leveling off. So a lot of what we spend time talking about, and I should say, so I work for Ray Chambers at the UN Special Envoy's office, but also lead something called the Financing Alliance for Health, which is really this point that Dr. Merson was bringing this morning of trying to actually give capacity to countries to help them think about their financing plan. And in a way, if GE or Novartis is going to go do a big deal, they hire an investment bank to help them think about how to structure that finance. And what's the mix of equity and debt to get there? But in the global health context, if a country wants to go actually build a community health strategy or develop primary care or build a whole new set of tertiary care hospitals, who do you call? And on the one hand, you can, the World Bank has classically played a bit of that role of being an advisor to the government, and U.S. Treasury Department has some good advisors. There's actually no one out there, if you look, who's actually able to help governments take a holistic view and think about the mix of financing sources. And where are we today with donor revenue? How much is our national government contributing? What are we doing with things like private sector and out-of-pocket payments? And what does that need to be by 2030? And what's that mix? And this is intentionally without data or specific dollar amounts, because in every country this mix will be quite different. And the baseline of where they are today, of how big that donor slice is, and what they expect, where they expect to be by 2030, will necessarily be quite different across countries, and be something that's going to change many times as well. But overall, the key point here is really we need to create fiscal space in all of these countries to do the big, bold strategies that they want to do. But too often that discussion around health planning has been divorced from the question around financing strategy. And it's only at the tail end that we bring them together, but really to what the GFF is trying to do as well. How do we bring those together at the start and create a financing plan along with a health plan or health strategy? And this was really, I think, also well captured in the report that came out last year, which probably many of you worked on, but talking about from billions to trillions, of how do we get to that aspirational target of much more funding that's required. So just as background, and I'll skip this, but basically we know that community health works. I don't need to tell this group that, but primary care and community health are critical. And this is just an example from Ethiopia, where we see the line in red is actually the decrease year on year of under 5 mortality, and meanwhile the black line at the top is the coverage of community health workers. So it's more correlative than causal, but there is a lot of evidence now sort of suggesting that expanded primary care and especially community health are critical to driving down under 5 and deaths as well as women maternal deaths. Excuse me. But what we hear again and again from countries is that they know this. They're trying to expand their primary care, but there's just not sufficient funding. And the question then becomes, well, how do you expand that funding? And I'd like to posit that it really begins with ownership of the problem at the ministerial level within countries. And what we're finding as we as the Financing Alliance work with countries, that those countries that are most successful really have political ownership of this at the Ministry of Finance level, at the Ministry of Health level, but then at the Prime Minister and President level as well. And a great example of that is in Ethiopia, of course, with Minister Kazete and Minister Tedros, but also Prime Minister Hailemariam owning primary care. But we're now seeing it, and I know Liberia is a country that Jendai knows well, but with President Sirleaf owning the rebuilding of her health system after Ebola. And likewise, we're now working in Sierra Leone where we're seeing the same thing happen, and Rwanda is a great case. And you're even seeing examples like in Pakistan where 89% of the lady health worker salaries were paid for actually out of the government's own pocket. So Africa is behind South Asia in really committing domestic resources, but we're seeing that trend happen, and it starts with modeling and political ownership at the senior level. And then sort of analytically, just the key steps of this are finalizing the strategy, doing the policy and the costing, and then creating a case, really of taking a case that can both be used internally to speak to the Ministry of Finance, but also then globally with donors. We worked last year, created this investment case and financing recommendations for community health, which found a 10-to-1 return on investment for investing into community health on an economic basis. And that's due to basically saving lives that then become productive members of society and contribute to GDP. Or here, it's actually here. Preventing against the next epidemic like Ebola, and then from employing people, right? Of every person that you're putting on payroll, there's a fiscal multiplier effect from that. And this is a global case that found a 10-to-1, but we're also doing it at a country level. So we've just done it in Liberia, which found a slightly lower return on investment because their GDP is a bit lower, but it's the same principle of making a case to your Minister of Finance that this is not just about health benefit, but about an economic benefit, and having that Minister of Finance really own that analysis. And it's an example that we're now replicating in Sierra Leone and hope to do in Rwanda soon as well. Let's move on. So this is a powerful argument, and it can also be used with donors. As I think Mark Dybel said this morning, all donors are interested in results-based financing, and all donors want you to also make a case economically right now. And we're trying to speak to that language. This is just a list, and I won't go through it in detail, but if you talk about sort of how you can get governments to actually on board with investing their own resources, you also have to give them options for what this financing transition can look like, and how to think about the portfolio of financing tools that are out there. Again, to this paradigm of, can you create an investment bank that supports countries in a way, and how do you think about the range of options that are out there? At the top are a list of sort of traditional sources of financing. So you have your bilaterals, your multilaterals, your NGOs, and government. And then below that are some of the innovative approaches that are now available. So the GFF certainly, but also the private sector, with actually companies are investing into community health because they see it and it's in their own interest. Revenue generating models. You have Avon-like sales ladies, right, who are taking a small commission but actually bringing products to market. Revenue bonds. We're working on something with Credit Suisse actually that's using IFM as a precedent, or using IFM as a background, but really trying to crowd in the capital markets as a source of funding. And then impact bonds. And Mariam mentioned the social impact bond in Cameroon. There's also something happening in India in primary care, but people are really experimenting with these types of tools. We don't need to touch on the GFF because we have our expert here. But this is just an example of the private sector investing. So in Anglo Gold Ashanti in Ghana is actually building their own community health model because they're seeing, actually it's hurting them economically, and they're seeing a 24% incidence rate in 7,500 cases. They were able to bring that down significantly by creating their own primary care system. And likewise, an Ethiopian sugar company created their own sort of primary care system around their base of operations and saw that both a reduction in costs and a decrease in mortality and morbidity. Briefly, Novartis Arogia Paravar, the Novartis guy is here, so I don't need to talk about that, but it's a great model of actually a private company getting involved in primary care and outreach. And then Living Goods, many of you may know, but this actually is the Avon-like model where community health promoters bring products door to door, and they've seen a 25% reduction in child mortality in the areas where they're working, which is pretty impressive. And again, these tools I don't mean to say are for everywhere, and they're not right for the poorest regions and those who have really no out-of-pocket disposable income. But again, it's a mix of financing sources, and we need to really go from billions to trillions, so how can we use all these different types of resources that are available? This is just a sketch of this human capital bond that I referenced, which is actually a capital markets tool that we're structuring with Credit Suisse. But the idea is for it to be a $200 to $500 million facility, actually a program of bonds, where a special purpose vehicle actually takes out the debt, and then the funding is then on-lent to countries. And we're hoping to have it 100% guaranteed, so that the rate comes down to something that's affordable by countries. And also to have grant providers as part of this to do pay-for-performance payments to actually reduce the coupon cost even further. It's going to take a long time to structure. It's complex. IFM was not built overnight, but we're optimistic that this is something that could become a powerful tool for some countries. Okay. And just to say, I've talked a little bit about the tools, but also to Dr. Merson's question from before, a little bit about the capacity to support countries in doing this. And we've created with partners, and the partners are listed at the bottom of this slide, this thing called the Financing Alliance for Health, which is really meant to serve countries, acting as a supporting governments in building primary care health systems across Africa, and serving as a facilitator between these worlds of health and finance, and being a thought leader on how we can actually increase the amount of financing that's available. The hope is to engage with countries, do knowledge management, and also develop innovative financing products. We've involved the World Bank, UNICEF, our office, Partners in Health, Last Mile Health, the Clinton Health Access Initiative, Living Goods, Total Impact Advisors, Millennium Challenge Corporation, USAID. So trying to really make this a partner-led approach, because unfortunately, while I think an idea of a cohort within Treasury or HHS could be great, the expertise that you need to do this, I fear, is actually not found all within the U.S., and we need a broad set of partners, many of whom are based in Africa, who can actually help countries think through this. The Ministry of Health of Ethiopia is also a leader with us on this. I failed to mention them. That just talks about kind of what we're trying to do with the Financing Alliance. I'll skip that. And then just to some specific recommendations for the U.S. government, because I know that this, part of the Commission's responsibility as well. The first is to really co-invest alongside existing financing mechanisms. We found an opportunity actually with the Global Fund for Integrated Community Case Management, where we were able to leverage $250 million from the Global Fund's Malaria portfolio to actually support community health, and then got bilaterals like USAID to come alongside that. And I think there's very many examples, and I think Lois mentioned earlier about nutrition being really good at this, but finding partners in working on similar things and being able to co-finance together, because the synergy potentials are huge. Unfortunately, too often there's a lot of challenges with aligning the timing of the financing as well as the metrics, and we talked about that earlier, but many of the donors, including the Global Fund, are reticent to take ownership of types of programs that they're not specifically financing. So not setting out metrics, they won't track metrics that they're not financing against. Second is creating more flexibility for innovative finance. So with that sketch of that human capital bond I mentioned, we're working closely with USAID and exploring whether DCA, for example, can actually do a guarantee. There's a lot of rules, as you can imagine, about what U.S. government can guarantee and not, and there would be greater flexibility in some of those guarantee programs would allow the capital markets to play a greater role, especially when the ultimate outcome can really catalyze that additional private sector investment. And then there's opportunity to really encourage cooperation between the U.S. government's development finance tools. So bringing together DCA, OPIC, the Global Development Lab, to maximize the impact. Too often it seems everyone's kind of working in separate areas. And finally, really investing in capacity. Again, back to Dr. Merson's question, but many governments are strapped for capacity in the community health and primary care systems, and especially with financing. Some countries, Liberia, for example, has just created a health financing unit. That's pretty rare. And having capacity that can serve in the ministry and help with planning and financing, I think, is tremendously high leverage. Programs such as the Asset Management Partnership, Tony Blair's African Governance Initiative, are a start toward that. There's huge opportunity to do more there that I think will return greatly for the U.S. government. So lastly, and I'm really not the expert on this, but I wanted to mention just a couple of mobile health tools because I know it's of interest. Two programs in particular, two companies, and these are just illustrative of the many companies that are working, especially in the community health space, but on primary care more broadly. One is ComCare, which is from Damagi, and is actually an open source mobile platform enabling non-programmers to build mobile applications for data collection. So if anyone can build these things, and they're great for collecting data, to Mark's Dybel's point earlier about the importance of data. And the second is Medic Mobile, which actually combines messaging, decision support, and data gathering and analytics tools. So it's more of the software piece. But these are just examples of the tremendous work that a lot of my partners in the mHealth community are doing. And as the evidence on the right-hand side shows, tremendous impact in terms of outreach to communities and also improving quality and decreasing mortality. So let me stop there. And I think, yeah, I've got more to go, but I can stop.
Thank you very much. It's excellent presentations. I should say very rich in the spirit of financing. And